Good morning. Today we'll continue with diabetes mellitus. In the last class we learnt about diabetes mellitus. We learnt about what are the types of diabetes, what is diabetes mellitus, what are the types, what are the risk factors, what are the signs and symptoms, diagnosis, complications and management. How do you diagnose based on FBS, PPBS, RBS and HbA1c. We also learnt about the management which included insulin and oral hypoglycemic drugs. In insulin, we learnt about how is it synthesized from the pancreas, secretion of insulin from the pancreas, mechanism of action of insulin, acting on the insulin receptors, physiological actions, pharmacokinetics, uses and uses. Today we'll learn about adverse effects, how do you classify insulins, what are the insulin preparations and mode of delivery. So we'll continue with insulin preparations. What are the preparations of insulin we have? We have conventional preparations, those which we obtain from the animals, like the bovine insulin, the porcine insulins. Bovine insulin differs from the human insulin by 3 amino acids, where the porcine differs by 1 amino acid. These were highly antigenic because they were from a different species. So they got highly purified insulins. How did we get highly purified insulins? By chromatography, gel filtration, chromatography. This was stable, but again they were little antigenic. So we went to prepare human insulins. What are human insulins? Human insulins are prepared through recombinant DNA technology. They're similar to that of any human insulin which is there in all of us. So this is as what is needed is how it is what is given. So how do we prepare human insulin? Human insulin is prepared by putting this insulin gene into E. coli, either E. coli. With this, where E. coli will be able to produce the protein insulin. This insulin is purified, collected, purified using chromatography, and then it is given. What do we call this kind of insulin as? It's called as human insulin. There are several preparations. This is also called as regular insulin. There are many brand names for this: Acrapid, Mixtard. So what will be the structure of regular insulin? Regular insulin will have the same 51 amino acids with 3 disulfide bonds. Regular insulin, you can modify this regular insulin. How can you modify? We can add zinc molecules. When zinc molecules are added into it, it forms hexamers. So around 2 zinc molecules, 6 molecules of insulin bind. Around 2 molecules of insulin, 2 molecules of zinc, 6 molecules of insulin are going to bind. When these bind, regular insulin becomes a little more longer acting. So insulin molecules aggregate to form hexamers around the zinc. After injection, these are slowly released. So peak action will be for 2 to 4 hours and duration of action will be for 6 to 8 hours. What will be the action of insulin? How long? It will be acting for 6 to 8 hours because zinc is added into it so that it forms a hexamer along with the insulin. What are the other preparations of human insulin we have got? We have regular insulin, we learnt about it just now. We have semi-lente, insulin lente, NPH, ultra-lente and protamine. To make insulin more longer acting than 6 hours, we can add certain molecules into it. Like if we add protamine, it becomes more longer acting. Like protamine zinc insulin acts for 24 hours. So these are insulin preparations. We have made regular insulin or human insulin shorter or longer acting by adding certain molecules like zinc or protamine. So we get regular insulin, lente, ultra-lente, NPH. What is the route of administration of this? Subcutaneous or IV. IV, we have to give regular insulin. IV, regular insulin. Next, coming to the next group of insulin preparations, those are called as insulin analogues or designer insulins. What are these designer insulins? We know this is the structure of insulin. If we are able to modify any of these molecules, any of these amino acids, and produce insulin which has different properties, those will be called as insulin analogues. So these are modified or genetically engineered. What does that mean? Simple. Here in the position of 28 and 29, there is an exchange of amino acids. Lispro, lysine, proline, they are interchanged. Lysine and proline are interchanged. This produces insulin lispro. Because of this interchanging, the lispro insulin, which is also a designer insulin or an insulin analog, becomes very, very short acting. So based on that, insulins, the furthermore insulin preparations which are added, like we have rapid acting, long acting insulins. Other than the regular acting insulins, these are the insulin analogues. So rapid acting, we have lispro, aspart, glulusin. Longer acting, glargine and Dettamom. So what did we understand about insulin analogues? These are modified amino acid sequences based on genetic engineering. These are produced. They are structurally different from regular insulin. So among that, the first one we learnt about insulin lispro. Here there is a reversal of proline and lysine at the B28 and the B29 position. What will be the onset of action? 5 to 15 minutes. Duration of action 4 to 6 hours. The next molecule in this is insulin aspart. What is happening in position 28, B chain 28? We are substituting it with aspartic acid. That's why it's called insulin aspart. Insulin aspart. You can see in B28 position, instead of proline, aspartic acid is added. What is glulusin? Glulusin is also a short-acting, rapid-acting insulin. So arginine in B3 is replaced by lysine, and lysine at B29 is replaced by glutamic acid. These are the short-acting insulin analogues, lispro, aspart, and glulusin. Coming back to the longer acting insulin preparations or insulin analogues, that is glulusins. These are structurally modified where you can see at the position B chain, position 3, it is changed with lysine, and at 29th position, you can see here at 29th, this is glucin. Coming back to glargine. Glargine is a long-acting preparation. Here, what are we doing? A21 is replaced by glycine, and 2 arginine residues are added onto the C terminus of the B chain. Means here we have glycine. Here, asparagine is replaced by glycine. This is in the A chain. In the B chain, in the end, in the terminus, there are two molecules of arginine which are added. Because of this, glargine, a long-acting insulin, can act up to 30 hours. Duration of action will be around 30 hours. Onset will take 1 to 2 hours. The other molecule is Dettamom. This is also a long-acting molecule where threonine at B30 is removed and mystric acid is added. To B29. You can see here threonine is removed and mystric acid is added. So what are the insulin analogues we learned? We learned about aspart, glulusin, glargine, lispro. Longer acting glargine and Dettamom. So now if we come back to this of classification of insulins, let's just go through it again. How are insulins classified? Insulins are classified into first short-acting insulins. This will include regular insulin, semi-lente, insulin lispro, aspart, and glulusin. Intermediate acting, we have lente and NPH. Longer acting, we have ultra lente, protamine zinc sulfate, and glargine and Dettamom. The glargine and Dettamom are insulin analogues. So when classification is asked, you have to combine insulin analogues along with the regular insulin preparations and has to be spoken about. Both of this have to be added on. So name all the short-acting insulins: regular insulin, Lispro, Glulucin, and Aspart. Longer-acting insulin analogues: ultra lente, protamine, zinc, glargine, and Dettamom. So this is how you classify insulin preparations. Coming back to insulin analogues. Insulin analogues are those insulins which are modified. We have Lispro, Aspart, Glulucin, glargine, and Dettamom. What are the advantages of this? These have got low hypoglycemic risk. They are good at controlling postprandial blood sugar levels. They can be used in computerized insulin therapy and can be given immediately before a meal. And they are useful for patients. So this is how insulin preparations are available, like ultra short, which are Aspart, Lispro, and Glulucin. Short acting, regular, intermediate acting. Long acting or ultra long acting, we have glargine and Dettamom. How do we administer? IV or subcutaneous? Insulin preparations which are given through IV, regular insulin, Lispro and Aspart. So where do you use insulin? Diabetes mellitus, diabetic ketoacidosis, hyperosmolar non-ketotic hyperglycemic coma, gestational diabetes, and hyperkalemia. So let's look into few of the adverse effects of insulin. Hypoglycemia is one of the common adverse effects of using insulin. What are the features? There can be autonomic features like sweating, hunger, palpitation, tremors, anxiety, tachycardia. If the blood sugar levels falls below 40 milligrams per deciliter, the glucose reaching the brain is going to decrease, where the patient is going to develop headache, dizziness, confusion, behavioral changes, fatigue, and can even land up to unconsciousness. So how do we treat patient with neurohypoglycemia? We have to give him oral glucose. If he is conscious, if he is unconscious, we have to give him IV glucose, or if IV glucose or glucose is not accessible, we have to go with IV glucagon. What are the other adverse effects other than hypoglycemia? It can cause weight gain. Lipodystrophy. What is lipodystrophy? Abnormal growth of the lipid. Growth is lipohypertrophy. If there is atrophy, we call it as lipoatrophy. These are common with conventional preparations like the bovine and the porcine insulins. These are not common with the human insulins. Other adverse effects could be allergic reactions, insulin resistance. So these are few preparations. Here we are seeing insulin Lispro, which is available in a vial. This is a insulin pen where it can be used. We have in insulin pen we have this pre-filled syringes which are going to be used. So how are we going to deliver insulin? Insulin can be given through a needle with a syringe. We have insulin syringes used for this. These are insulin syringes. Next, we have pen devices where into the pen the insulin vial is put into, and through this it can be given. Here you see insulin pen, and what you see on your left side are the insulin carrying cartridges. The next one is the pump. The pump inside of it will have this is the pump. Inside of us, it's a Medtronic pump. Inside of this, we can put the insulin cartridge. These are programmable just like any electronic instrument, just like a video game where it can be programmed, and this can be fixed onto the body. And it can release insulin as per the need. So what are this Gluco Watch or AccuCheck? These are used to measure blood sugar levels, to measure FPS, ppbs, rbs. These are few of the blood sugar measuring or blood glucose measuring devices. So what did we learn now? We learned about how do we deliver insulin. Insulin is delivered through syringes, pen devices, computerized. We have inhaled insulin, and we also have oral insulin, which is under trial. Inhaled insulin is already in the market. What are the types of insulin? There are several types of insulin preparations. What we have got, we have which are used. We have regular insulin. Other than that, we have lente, NPH, longer acting, ultra lente, protamine, zinc, insulin. Along with this, we have insulin analogues. What are these insulin analogues? These are rapid acting or longer acting insulins. Lispro, Aspart, Glolucin, Gargin, and Dettamom. Any of this can be mixed to achieve concentration. Like Aspart, we can give 30%. We can protaminate it, and 70% of this protaminated can be added. Why do we do this? We do this in order to give insulin so that it mimics the original release of insulin. Here, if you look at an example, if you have to give insulin in a patient, we'll have to give insulin 4 to 5 times. If the duration of action of regular insulin is 4 to 6 hours, we have to give at least 4 to 5 times a day. Instead of that, if we are able to mix regular insulin along with the NPH or a longer acting insulin, we'll have to give it 2 times. If you look at the diagram below, you'll be seeing where you can give a biphasic insulin. So there will be 1 and 2 injections only. So this will be a regular insulin, this will be a NPH, a longer acting. This will be regular, this will be NPH, which is taken in 1 syringe and it can be given. These are called mixed insulins, or where you can combine, which are pre-madely available. These are few examples of how we can even combine insulins for insulin preparations. With this, we conclude the insulin preparations. So insulin as a main question, we need to learn how it's synthesized, how is it secreted, what is the mechanism of action, what are the physiological actions of insulin, what are the insulin preparations, uses and adverse effects of insulin, and what are the insulin delivery devices. In the next class, we'll be learning about oral hypoglycemics. So with that, we conclude the class. Thank you.